Hello, everyone, and thanks for joining our webinar on patient-directed research. I'd like to introduce you to our doctor who is joining us tonight. That's Dr. Vincent Martin. Dr. Martin is the professor of clinical medicine at the University of Cincinnati in the College of Medicine, where he received his MD and completed his residency in internal medicine. He's written over 60 articles for the professional literature and contributed 10 chapters to various headache textbooks. Dr. Martin serves as the chair of the NHF Research Committee and has conducted many studies on headache. Dr. Martin, would you like to begin?
Sure. I think the purpose of this webinar is to find out what patients might think is important in the headache research field, because in the past, physicians have kind of driven ideas on what they think might be important research, and it tends to be often very specialized based on the very narrow field of interest that the physician might have in a given research area. But what we're planning on doing tonight is trying to hear your questions and your ideas on what you think is important in the headache field. And then, based on that, we will take some of these ideas forward, and the National Headache Foundation will actually really send out what we call a request for a proposal. That means we'll request proposals from the headache community within a specific area that you deem important, and we'll fund a research project based on this. So really, it's one of the very first times ever that patients are going to be heard, and we want to hear what you think is important in terms of research being done to help you and help others in the headache field.
Great. We actually have one of the members, John, would like to see more research into the effects of long-term use of triptans. He has used them since they first came out and find that he's more susceptible to migraines now than he was before.
Well, that's a great question, and I think that probably one of the big things in the headache field right now is this whole issue of what we call medication overuse and what patients call, what lay people call rebound headaches. And there's always this kind of yin-yang as a headache physician that you have with patients, in the sense that, the patients are having really frequent headaches, and it makes sense to try to take medications to relieve the headaches. But at some point, some threshold is hit above which you start actually inducing headaches, and those are called rebound headaches. And it depends on what kind of medication you're talking about. But usually when people get to have more than about 10 days per month with triptans, then there's a question of whether the triptans might actually be kind of adding to the problem and causing more headaches. So, but there has been some research in this area where they've kind of made the triptans are given a much more liberal use. And I think there's a lot of controversy in the headache field about whether more liberal use of triptans would actually make the headaches worse or not. So I think that's a great idea. The question is, are there some patients that could use the medications more liberally and not cause these rebound headaches? And there might be some other patients that might not be able to do that. So trying to figure out which patients might be more prone to develop these medication overuse headaches, particularly with triptans, I think is a very important question. The other issue, too, is with the HMOs and all the health plans, for example. They've got all these restrictions on the triptans, and it would be nice if we had some data about more liberal use where you wouldn't be limited to, say, 6 or 9 tablets per month. So I think that's a great idea. That's something we'll put down on our list as a possibility.
We actually have a question similar to that on the opposite end, though. How much research is being done on those who have migraine symptoms but do not respond to triptans? What relief can they find, and why wouldn't they be responsive to triptans?
Well, that's also a very good question. You have to understand that the way most clinical trials are funded are through the pharmaceutical companies. So there's a great tendency to study the drugs that the pharmaceutical companies make money off of. So consequently, there's literally hundreds, if not thousands, of studies on what we call the triptans. Those are drugs like Imitrex or Zomig or Maxalt, which is rizatriptan and so forth. But there really aren't that many drugs for other drugs outside the triptans. There are a few. but not very many. So I think trying to develop other therapies to help migraine patients is critical. In fact, probably only about 2/3 of migraine patients can actually respond to the triptans or can take them long term. And one of the big issues is tolerability. There are many patients who develop bad side effects to the triptans, and even if they do respond to them, they can't take them long term because the side effects are so troublesome. So to start studying some acute medicines that can help treat, the pain of headache when migraineurs have migraine, I think is a very, very important question. But there really are not that many therapies outside the triptans. They're trying to develop some new therapies out there. There are some things that are not close to the horizon, but maybe in the future there are actually drugs that block something called CGRP, called calcitonin gene-related peptide. But the problem is some of the early drugs that have been tested so far have had some liver toxicity to them. So consequently, none of them have kind of come to market or even gone into what we call phase 3 trials, which are more advanced, trials of clinical research. But I think if we could develop some drugs, as you suggest, that are non-triptan therapies for people that fail them, it would be a huge advance in the headache field. So I think that's also another excellent suggestion too.
Then we also have Chris asking, now that marijuana is legal in Colorado and Washington State, is it possible that marijuana could be studied for the prevention or treatment of migraines?
I think that's a controversial topic. While it may be legal in several states, it's still illegal in the vast majority of states in the country. Now, if you're asking me from a scientific standpoint, so I think, well, actually, before I go to the scientific standpoint, so to answer, so there's some issues with, with acceptance of that and the legality of that in many states in this country. So that is a big issue. But if you're asking me from a scientific standpoint, do I think that might have some merit? I think it could. There's something called cannabinoid receptors in the brain that bind marijuana and other marijuana-like, drugs, and those may have some analgesic effects or pain-relieving effects. And there may be situations as well where these drugs can help relieve nausea, and nausea, as you know, is a big symptom of migraine. So I think that's a possibility. I would be surprised if marijuana in the form that you think of it would be ever studied, but I could see it, being studied in a drug formulation like Marinol or something like that. That's a marijuana basically synthesized compound. So I think it's possible, but I think with all the legal issues and legalities in the various states, that studying that would be somewhat challenging in today's climate.
Ray is looking to see some study on adequate progress, namely comparing the perceptions of treatment adequacy between patients and providers. Is there a specialty pedigree of the provider?
A specialty pedigree. Well, I think that it depends on what you want. There are all sorts of national organizations that will tell which members are in their organization, and that's probably your best judge for trying to find a provider. Like, for example, the National Headache Foundation has lists of physicians that you could access, and in addition, so does the American Headache Society has lists of physicians for patients. Now, in terms of within that list, deciding which ones have a pedigree that you can trust, I think that is somewhat difficult. You can look at the publications of the person. You can look at whether they're have officer positions within various organizations to assess their credibility. If you have any medical knowledge, then one might be able to read some of their articles and tell whether or not they can make those decisions. Now, in terms of making decisions, in terms of what kind of treatment strategies and medications one might use, there are a number of national organizations that do come up with different what we call algorithms of care in different situations. And there's something called the U.S. Headache Consortium that comes up with various treatment approaches. But what's interesting is what the physician may value in a treatment approach may be completely different than what a patient values. So I may look at a patient and I might say, well, you know, your headaches are not, you're still having headaches on a daily basis, and you're still having headaches with a level 9 on a scale of 10, and you know, on a daily basis. And I would think to myself, well, you're not doing very well. But then I'll say to the patient, you know, like, well, gee, it doesn't look like we've really helped you in this instant. And they'll say, no, Dr. Martin, you've helped me more than any other doctor, because now, you know, my level of 9 headache doesn't last the entire day. I'm able to function, I'm able to go to work, and so forth and so on. So I think sometimes there's a disconnect between what the physician's expectations might be and what the patient's expectations might be in terms of a treatment response. So I think that some sort of study that looked at, you know, the doctor's expectations and the patient's expectations and see whether they're the same or whether they differ, and what patients really want would be important. Now, in some cases, when you ask patients long lists of what they think are important in medical care, oftentimes they want everything, and sometimes the patient's expectations can sometimes be unrealistic based upon the treatments that we have now and what the response might be for a given medication or given medication category. So I think it kind of goes both ways. I think sometimes the physician may not be picking up on what the patient wants, but I think it goes the opposite way too, where sometimes the patient thinks, for example, that if we put them on a preventative medication, that there's going to be a complete cure. But in reality, that's just not practical. So I think looking at research that kind of tries to develop more, you know, joint goals between patients and physicians would be something that would be quite important as well.
Yeah, put it another way, Ray says, does the specialty certification of a provider have any influence on patient adequacy of treatment?
I think that it does. You know, the United States, you know, it's called the UNCS. UNCS has a board certification that I've passed, and that's something that you can get some idea of whether, you know, patients have, or that physicians have some qualifications for, you know, for headache management. In addition, there is a certificate of adequate qualification that the National Headache Foundation has awarded to, I think it's either 50 or 100 physicians nationwide, signifying that they've achieved some level of competence. So you could look for board certification, but that doesn't absolutely guarantee someone's going to be the right doctor for you. I think that the doctor-patient relationship tends to be one it's like any other relationship. You have to find a person that you think can listen to you and that can be compassionate with you and that's responsive to you. And it's more than just being able to pass a test. So I think you could start with looking at board certifications or certificates of added qualification, like or that the National Headache Foundation offers. But I don't think it can really end there. I guess the other thing you could do is there's a variety of different online services where they rate the doctors and so forth and so on. And I guess you could look on those, you know, on those online sources to see whether or not the patients actually like the physician. So the way I look at it is there's two components to this. I think there's the knowledge, but then there's also the bedside manner and all the other components of the practice that are thought to be important by patients in terms of their management. So I think that you might have to hit on both to find the right doctor for you.
Mary says that she understands that the brains of chronic migraineurs change over time. Is there any study, or could there be a study doing something like MRIs of those with long-term or chronic headaches or migraines to understand how the brain changes?
Well, as a matter of fact, we sent out, the National Headache Foundation sent out some requests for proposals about 2 months ago. And one of the studies was looking at different brain imaging, looking at special kinds of MRIs of the brain in patients that whose headaches went from daily headaches. They basically had what we call chronic daily headache, which are 15 or more days per month with headache, and they looked at the MRIs. They proposed to look at the MRIs in that group, and then the patients that then improved from 15 or more days per month down to less than 15 or days per month of headache would then have their MRIs to see whether there are differences in brain function between those two groups. So that idea has already actually been funded by one of the National Headache Foundation grants that we just awarded in the last 2 weeks. So that's an excellent, also an excellent point by the audience. So we're working on that.
Yeah, we also have another question about brain donation, because I actually get calls about this as well. Is there any way to donate your brain to science or something to study the brain after a person has passed away, or is there any complication with that type of research?
Well, you can always donate what you probably want to do in that situation is if you want to donate your brain to research in some way, you'd probably have to find a medical center that's doing research in the area that you're interested in. So, for example, if you wanted to donate your brain, for Alzheimer's research, then you probably have to be in touch with some medical center that's doing some high-fluting research in that particular area. So I think that it is possible, but in most of the research that's being done, say in the headache field, is not looking at brain samples after people have died, although I can think of several ideas along that line, because right now there's something called white matter disease in the brain. And many of you may have had MRIs, and the doctor tells you that there's something called white matter disease on your MRI. And then the question is, what does that mean? And we don't really know. Because there have never been any large-scale studies that have actually looked at patients' brains that have actually had these white matter changes to know what they really are. I mean, we think that it could be low blood flow of the brain, or maybe that migraine damages the brain over a long period of time, but to have a series where you could actually look at the brain and actually try to see what these white matter changes are doing could be a great advance. Some of the other things, like the only problem with looking at just autopsy specimens of brains is that you don't really get a good idea of what the function of the brain is, and that's why some of these neuroimaging, some of these special MRI studies like we talked about with the last question, I think are really exciting. We're able to look at how all the different functional connections of one part of the brain to another, and it's really pretty amazing stuff. So yes, I think that autopsy stuff could be helpful for certain questions, like if there are some structural things like these white matter changes that you could see, and then actually look at the autopsy brain and then figure out what might be going on with those, or what might explain those white matter lesions. But it's not going to answer many of the other questions about migraine that require an intact brain with functional connections from one area of the brain to the other. I think those are going to have to be answered by live studies. And probably imaging studies.
Yeah, we also have a comment from Calissa that she has a Critochrome P450 genetic testing that showed she was a poor metabolizer. And her understanding is that the poor metabolism affects the metabolism of tricyclic antidepressants, which she uses for chronic migraine prevention. And she'd be interested in research on how drug metabolism affects headache prevention.
Well, I think that I think drug metabolism is a great area, because we assume in the medical field that everyone really responds pretty similarly. The drugs are metabolized the same way, and all the different drug targets in the body are the same from one individual to another. But we know that that's just not true. Certainly, people who are slow metabolizers of the tricyclic antidepressants will end up having really high levels of these drugs, and they can have really serious side effects on the heart and other organs if those levels go really, really high. So fortunately, those mutations for that particular drug are pretty rare, and it doesn't really cause a problem. But I think in the future what you're going to find is that before you give a patient a drug, you're going to know how the drug's metabolized, how the patient's genetically going to handle that drug. Is it going to, is it a good drug for, like for example, are the the right receptors in the brain present for that particular drug for it to be effective? How is it metabolized? If we give the drug, are you going to have a side effect? So I think, we're probably several decades away from that kind of knowledge kind of on a more broad basis, but we do have some genetic tests right now for certain drugs that are heart drugs, for example. They have ways to check tests to see if someone's going to have a particular side effect of the medication. That's it's called pharmacogenomics. So it's basically using genes to figure out, not only how patients metabolize drugs, but whether they're going to be effective or not. That's even more important in the headache field, because right now with preventative medications, we often have to try many, many different drugs before you find one that's effective. And it's complete trial and error, and you're subject to what your doctor might think is the best medication for them, or they think the best medication for their migraine patients. But sometimes that may not be the right one for you. In this targeted world, where we know how the genes that help decide how a drug is metabolized and how a drug is is going to be effective, can help us really choose what's the best drug for that individual patient. So we're not close to that right now, but I think studies that would look at drug metabolism will be very key over the next probably 10 or 20 years.
And then we also have a comment on how children have what's called abdominal migraine, and it's also very rare, but I've heard that it's possible in adults as well. Is there any connection between gut flora and migraine, or the GI pathways and how they relate to pain?
The answer is people propose that. For example, there's something called H. pylori, which is a bacteria that is thought to be important in producing ulcers of the stomach. And there have been some studies that have shown, for example, that that patients that have this H. pylori in their stomach, which is not typically found in patients, that don't have either inflammation of the stomach or ulcers, that those patients have a higher likelihood of having migraine. So there probably is this connection between the migraine and the gut that's very important. It's probably not all explained by an infection, for example. Like with abdominal migraine in particular, there's thought to be some dysfunction of what we call the autonomic nervous system. That's kind of the fight or flight response that you have. Like if you're in a real dangerous situation, there's a part of that autonomic nervous system called the sympathetic nervous system that secretes like epinephrine and something called norepinephrine. Those are your kind of fight or flight hormones. Well, anyway, this whole autonomic nervous system that kind of is real important in that fight or flight response is abnormal in patients that have abdominal migraine. So not only can that abnormal autonomic system theoretically provoke the symptoms of abdominal migraine, which is abdominal pain and usually vomiting, but it can also induce head pain as well. In addition, they're finding that that there's something called a mast cell, which is this particular kind of inflammatory cell that lines the gut, and they found that when you do biopsies of the small bowel looking for these mast cells into the gut, that actually those can be found in greater proportions in migraine patients and in those that don't have migraine too. So there are a variety of different ways that the gut might be connected with migraine, either through certain kinds of infections like we talked about with H. pylori, or through this abnormal autonomic nervous system like we talked about with abdominal migraine, or even through other inflammatory cells in the gut that either themselves might have some neurologic effect, or they may just represent markers for increased activation of those inflammatory cells, maybe elsewhere in the body, maybe in the lining around the brain. So the mast cells in the gut may just be reflective of an increased number of mast cells somewhere else close to the brain, which then might explain why it influences migraine. So I think there's a number of ways that the brain and the gut might be interrelated with one another.
We also have a comment about how there doesn't seem to be a lot physiologically known at the onset of, or what are the changes that physiologically happen in the brain at the onset of a migraine and during a migraine. And is there any current study that's been going on with transcutaneous electrical nerve stimulation in relation to as a therapy for migraine?
Well, there happened at our very last national meeting, which was back in Boston in June, there were some studies looking at imaging studies of the brain, so like MRI studies of the brain, during something called the migraine prodrome, which is the prodrome is where it actually occurs before the aura and before the headache phases of migraine, and that's where people kind of develop symptoms like where they want to eat all the time, or some people have increased sexual activity during those times, or some people might be real thirsty and drink a lot. You might feel really tired before this, and these are all symptoms that occur before what we would traditionally call a migraine, but these symptoms of the prodrome can precede migraine by anywhere from 6 hours up to 96 hours prior to a migraine attack. And they've done imaging now for the first time during the prodrome in patients and found that certain areas of the brain are light up. One is called the hypothalamus. That's kind of the area that controls your wake-sleep cycles, and when you wake up, when you go to sleep, your circadian rhythms, a lot of your reproductive, like your sexual function, and so forth and so on. And so we think that this area of the brain is one that tends to become activated very early in a migraine attack. And if we were able to identify, what gets activated early and particularly what kind of changes within cells are occurring at such an early time period, you might actually be able to develop some therapies that you could intervene basically during the prodrome, and the patient may never even go on and develop migraine later on. So I think that there are many investigators now that are starting to look at imaging studies in particular during very early phases of the migraine attack, and even sometimes in the migraine prodrome. So I think that research is ongoing.
All right. Rob also mentions if patients are having more than 15 days per month and should not be using acute treatments more than 9 to 10 days a month, how do you appropriately treat the number of attacks without further progressing or promoting medication overuse headaches when using acute treatments? Is there a potential to study the various strategies?
Yes, I do. I think that there is the potential to study different strategies. I mean, the biggest strategy is to get a person that's consuming, say, 10 or more acute medications on 10 or more days per month, because it's not just total doses; it's number of days per month of use. You're going to want to get those people on preventative medications, basically. So you have to find a reasonable preventative. Now, if people are on preventatives and they're still having, a very good preventive regimen is still having these headaches 10 or more days per month, then there could be different strategies one might undertake. Most people in the headache field, at least right now, are really, going away from the use of any narcotic meds like opiates and any what we call butalbital-containing meds. That'd be like Furanol and Furoset, because those meds seem to have a higher propensity to cause these medication overuse headaches, or what you would term rebound headaches. Drugs like anti-inflammatories in particular probably have a lower propensity to cause the rebound headaches, but nevertheless can do it as well. One study I had thought about would be, because of this whole fear of medication overuse, there's some doctors in particular that don't recommend any narcotic medications whatsoever, and that seems to be like a constant struggle between headache physicians and neurologists and their patients, because the patients will hit a point where sometimes the typical medications don't work, and then what do you give them? There just frankly aren't that many medications to use, and many of the headache clinic doctors actually would prefer to give patients what we call antipsychotic medications, which are medications used to treat like schizophrenia and other diseases, as acute medications with almost very little data that they actually work. Whereas primary care physicians tend to take a more practical approach to treatment, and they're probably more liberal use of using the opiates like things like Tylenol 3 and Vicodin and so forth. So there's this big controversy about whether opiates can be used at all in headache patients. And one thing I've always contended was I couldn't believe that some small quantity of opiates used as what we call rescue therapy. That's where if you fail your primary therapy, that you've got something else to use to kind of keep you out of the ER. I've always thought that if you could use very small quantities of these medications just to keep people out of the ER, then the chance of that inducing medication overuse headaches would be quite small. But what threshold that would be is hard to really know. But one study could be that you could take people that say that respond to triptans, for example, and but they might need a medication as backup, and you could give half of them opiates as at a very small quantity, like maybe 5 or 10 tablets per month, versus another group that didn't they got some other therapy. Maybe they get anti-inflammatories as a backup. And then you follow them forward and see whether their headaches actually increase in frequency. So I think that, developing some studies that study these things that many headache doctors are considering just gospel truth on almost no data, I think could be a big benefit to the headache community. So I think different strategies of abortive medication use, particularly how do you manage these people that are kind of going into the real frequent headaches, and they feel like they need different types of meds. Now, from a practical standpoint, you ask, well, what do I do? What I try to do is a number of different things. I try to get patients on an adequate preventative medication. So a really potent medication. I might actually combine 2 or 3 different medications together, and then I try to give them anti-inflammatories as opposed to narcotics and/or barbiturate-type meds like Furanyl or Fioricet. And if they are consuming those when they come in, I try to wean those down to levels that I think are unlikely to cause medication overuse. And oftentimes I give them things like intramuscular shots that they can take. There's one called Ketorolac that I often use, and that can be administered a couple of days per week. It's very potent. And then I try to use triptans a couple days a week. I almost kind of vary my medications. In some instances, I might say, well, you could use your triptan a couple days a week, and you could use this intramuscular Ketorolac for a couple days a week. And then I try to also have them learn biofeedback and relaxation techniques where they can start learning how to manage their mild to moderate headaches without taking a medication. So that's basically how I would answer your question.
Deborah was asking, when you develop chronic migraine from analgesic medication overuse headache or for other reasons, not all patients revert back to episodic migraine or headache once you remove the medication overuse. Is there any study on why that might be happening?
Well, one possibility is that the medication wasn't causing the headaches to begin with. So you can't assume that every person who's got real frequent headaches that's using too many medications is actually, that the medications are actually causing the headaches. When you look at clinical studies, they found that when people are overusing their medications and you withdraw the meds, there's about 65 or 70% of the time the headache patients will improve, but there always are situations about 30% of the time where you'll remove the medication and that doesn't really do anything for the headaches. And what that means is that, in my book, is that it probably means that the medication just wasn't driving the headaches. So I think that, figuring out what could be driving headaches in those patients is very important, although I would have to admit that would be a quite challenging study to do because there really are probably tens, if not hundreds or thousands of different causes why patients might have headaches that might, not decrease in frequency after you withdrew the overused medication. Now, a lot of times there's probably been some damage to the nervous system in some fashion, either by some trauma or a past infection or some other thing that we don't really quite understand that might be driving the headaches as well. But I think that if we could figure out, what are some of the causes for headache in people that maybe aren't being driven by medication overuse, I think it would be important. I would say this, that right now there's really not much research being done in that vein. It almost seems like every time I go to a headache meeting, all the doctors want to talk about is medication overuse, medication overuse, medication overuse. That's like thought almost to be the whole answer to this chronic migraine question. And I don't buy it. I think there are lots of things. I can think of many different things that might still trigger headaches. I mean, there are different hormonal issues, that are not necessarily related to medication overuse that could trigger headache. There are, like I said, traumas, infections. There could be stress, for example. If you've had some real stressful life events, for example, it's very possible that the hormones that get kicked up and the other chemicals in your brain that get altered by the stress could change your brain. And who knows, it might even change it in some cases, irreversibly. So I think there are many different things that need to be looked at, but I think that it would be very interesting to look at some factors that don't relate to medication overuse.
And a question I know that you've personally done some research on is about weather and headaches. And what is the relation exactly between weather and headaches, and why does barometric pressure seem to affect some people, not others?
Well, this is something that we did some research on recently. I'll share you some. Well, we can talk about barometric pressure in a second, but I'll just tell you briefly about the research study that we did and published about 6 months ago, where we looked at the effect of lightning on headache. And what I didn't realize was you can actually purchase lightning data. There actually is a company that has weather sensors all over the country where when a lightning strike hits the ground, you may not realize it, but there are electromagnetic waves that emanate from one lightning strike, and depending on when they hit, the timing of when they hit these different sensors, they can tell whether a lightning strike occurred, where it was located, what's the amperage of the current of the lightning strike, and so forth and so on. So we actually purchased data from this company, and we got all the lightning strikes within about a year's time. And we basically, the bottom line was, and we had people that recorded daily diary data, and we found that if there was a lightning strike within 25 miles of a patient's home zip code, then there was about a 30% increase in the frequency of headaches. We then tried to create mathematical models of the other weather variables to determine, well, is it the lightning or is it the other weather factors that occur along with the thunderstorm that could be provoking the lightning. So we were able to do some mathematical, testing to see which was the cause. And even after you accounted for the effect of all these other changing weather variables, lightning was still predictive of migraine, of increased frequency of migraine. So that's one thing that we just published that actually, got international recognition. It was just a real trendy topic. Now, since then, the effects of barometric pressure on headache in the literature is somewhat conflicting, but we're actually doing some new studies which I think are going to be groundbreaking, looking at the effects of barometric pressure on migraine. And I think that there is a very strong possibility that barometric pressure is going to be a very strong provocative factor for probably the majority of migraine patients. Anywhere from 50 to 60% are probably going to be sensitive to the effects of barometric pressure, and so forth. And I can't really share a lot more with you on that because we haven't made our results public yet. But suffice it to say, I think that that weather, in my opinion, may be the strongest of all of the weather factors right now. And if we were able to develop models for weather that could tell a person that they were going to have a migraine on that day, that it would change the whole equation of how we treat migraine patients. For example, if you could say, all right, today's going to be a really bad day, and these are the things you need to do to try to prevent your headaches on that day. So instead of taking a migraine preventative daily, you could look at targeted therapies on these patients that might actually make a huge difference in trying to prevent headaches in patients. So I think weather is just an enormous trigger, and I think barometric pressure is I think it's probably going to be the driver. But like I said, I can't really share much more with you about that because we're doing studies on that right now. But I think that's one of the big questions in the entire headache field is how weather triggers headaches, and particularly during certain months like springtime, there could be 10 or 15 different systems that come through a given area in that month. So the weather could potentially be accounting for 10 or 15 days a month in some people that are weather sensitive. I mean, it's just an enormous trigger, and how to find ways to prevent weather-triggered headaches, I think, is very important, particularly for areas of the country where there was a lot of changes in weather.
Just as a quick addendum to that, and also environmental in a way, would solar flares technically be something that could be accounted for in a similar fashion of the weather changes as well as being a precipitating factor?
Oh, absolutely. There have been some other studies where they've looked at geomagnetic radiation, for example, and found that seems to be that's related to different solar activity. Found that is related to the occurrence of migraine, the frequency of migraine. But I wouldn't be surprised if events on the sun, for example, particularly if they're real prominent, where they shower the Earth with different electromagnetic radiation, I wouldn't be surprised if some of those might be very important in migraine, which is kind of, when I think of that, I think, wow, that's almost like, it almost sends goosebumps down my spine, because if you start thinking about, now you're not even talking about just meteorologic effects, but you could be having effects of, solar radiation, from the sun. I mean, that's just like almost Star Trek type of stuff. But yes, there is some data looking at that in migraine. It's very, very preliminary work. But I think that studies along that, I think, would be equally interesting as some of the weather stuff that we've looked at. So, and it would also be very, very easily studied too, because you can actually purchase all that data. You can purchase when there's how many solar flares they had per day. There's different. I think it's called a K factor. There's other things. You can purchase all this stuff, or actually get it on the internet on a daily basis already. It would not be a hard study to do.
Our next question is actually about the relationship between allergies and headaches, and possibly if there's anything like deeper studies that go even to something like the immunoglobulin G antibody response.
Well, we're just getting ready to publish a paper that will come out next week, looking at the effects of something called rhinitis. And rhinitis, it can be either allergic or what we call non-allergic. So there's an allergic rhinitis and a non-allergic rhinitis. And you say, well, what does that mean? So allergies in particular. So if you have like nasal congestion or sniffles or postnasal drip, and then you develop these symptoms upon exposure to an allergen. So an allergen would be something like cat hair or dog hair or dog dander. It would also be things like, grass, freshly cut grass, would be like tree pollens, which would peak during the springtime, or mold that would peak during the fall. So if you develop, these symptoms of, like stuffy nose and so forth, and you have an allergy test that's positive for one of these exposures, then you would have allergic rhinitis. Now, there's something called non-allergic rhinitis, where you develop these nasal symptoms, same nasal symptoms, except when you do your allergy testing, everything is negative. And in many instances, these symptoms are provoked by non-allergic triggers, like gasoline, perfumes, cigarette smoke. These are all considered non-allergic triggers. So there's non-allergic and allergic triggers. What we found was that if patients had rhinitis, or if you would call it hay fever, that they had about a 30% increase in the frequency of headache. So there's something about patients that have these hay fever and rhinitis symptoms that seem to place them at increased risk for migraine attacks. There's also another form of rhinitis, or like I said, there's allergic and non-allergic. There's something called mixed, where they have both allergic and non-allergic triggers, and we're going to report for the first time next week that if you have rhinitis that has both non-allergic and allergic triggers, that those people were like even much more likely, like 45% more likely to have frequent headaches. So there's something about people that respond to both allergic and non-allergic triggers that makes them almost like a super, what we'd call a phenotype, but a super type of migraine that makes them much more susceptible to headaches. And I think one of the biggest areas in this, you talk about disconnects between patients and doctors. I'm mostly in a neurology field right now, and neurologists are absolutely excellent doctors, and I'm not. But one thing is, when they start hearing about things outside of their own field, like allergies and sinus stuff, that they just can't believe that could play any role in migraine. But yet, when patients come in and talk to me, they always tell me, well, I've got two types of headaches. I've got my migraines and I've got my sinus headaches, and the whole headache community right now thinks that sinus headaches are a bunch of bunk. And, that you develop this pain over your cheekbones or your forehead or between your eyes or in your nose, and then you have all these symptoms of hay fever and so forth, and they really believe that that's all completely unrelated to migraine. But yet, when I see patients in my clinic, I would say that most of these patients have rhinitis. Now, so defining the relationship between sinus disease and allergies and rhinitis and headache, I think, is of the utmost importance. And I think it's also possible that weather and these rhinitis symptoms may be in some way, shape, or form connected. Who knows? Maybe there's pressure changes within the sinuses that might actually activate nerves that might trigger migraine and so forth. So I think that allergies and sinus do play a role in headache, and it wouldn't surprise me at all if allergic triggers or non-allergic triggers might actually provoke headache. And I think that learning more about how these triggers could provoke headache and therapies that could be used to blunt, say, rhinitis symptoms or hay fever symptoms, I have a feeling might actually improve migraine. So there's a lot more work that needs to be done in the headache field to further clarify these things. I think these are enormously important questions.
We actually have a request to clarify specifically about the transcutaneous electrical nerve stimulation. There's things like the Cephally that are not currently approved in America yet, but they're approved in some European countries. Are there currently studies being done to see if that's an effective treatment?
Well, there are some different electrical stimulators, different patches, and so forth that are not commercially available, at least in the States, that are being studied right now, particularly stimulators that involve the occipital nerve, which is in the back of the head. There was a recent study at our national meeting by Gretchen Tietjen out of the University of Toledo that looked at electrical stimulation of the skin, of the scalp, and found that it really had no effect on migraines whatsoever. So I think that, at least from what my limited knowledge of the data that I've seen, there is not great data looking at transcutaneous electrical stimulation. Now, there are some magnetic stimulators, for example, that actually where they put a magnet towards the back of the head, and they've in one study they used that in patients that had something called aura, which is where you get visual symptoms like flashing lights or zigzaggy lines that occur right before a migraine. And they gave people this electrical stimulator right during that aura phase, and found that they were actually able to stop them from getting a headache. So I think there is some. I'm not saying I think there is some value into some of these kind of therapies, but the magnetic stimulator actually probably has an effect, magnetic effect on the nerve cells in the brain. So, and I think that's a very novel therapy, and I think they may actually be looking at this as a preventive therapy as well, this transmagnetic stimulation, basically where they put these big magnets by the head, and maybe you put them on your head, or they put the stimulator over your head for a certain period of time, or who knows, maybe if a weather front rolls in and if you're lightning sensitive, maybe depolarizing your brain with a stimulator might prevent that headache. So there's all sorts of things that one could study looking at all these different stimulators, and maybe even the trans-electrical stimulation could be looked at in different fashion. But at least so far, at least the trans-electrical, I've not seen that there's really great data on that.
We also have another comment that perhaps something like melatonin or some of the other herbal or supplemental remedies that don't have as much pharmaceutical backing would be a good study more or less for the National Headache Foundation, since they're not as expensive. Something like melatonin has proven effective for many people. Is there a possibility of further research on certain supplemental treatments?
I think that those are things that are not often studied a lot. There have been a lot of different small studies looking at herbal therapies and different mineral therapies in migraine. There have even been studies looking at melatonin, particularly in cluster headache, and a few in migraine, but these are not real large-scale studies. But I think to fund some research on alternative therapies would be really important. There's also different medical foods out there. For example, when you say, what is a medical food? It's basically where you have, you basically ingest these tablets or capsules that have certain combinations of amino acids. They're found, or protein that is found within the normal diet, but they give it in different proportions with the thought that maybe certain individuals with migraine might be deficient in certain amino acids. And I think that looking at studies that look at medical foods, which would be another alternative therapy, would be something that's important as well. So I think looking at some alternative therapies that have very low side effect profiles would be of great benefit to patients, because if patients are able to purchase some things over the counter that would function very effectively as preventives with low side effect profiles, that would be in their best interest. So I think that alternative therapies is very possible a study that the NHF might be willing to fund.
Do you think there will also be any further longitudinal studies on different medications, much like we talked about with the triptans, if there's any long-term side effects for that? Something along the lines of like Botox or other treatments that are currently being used?
Well, I think if you start looking at, like, just take preventive therapies, for example. A lot of these clinical studies, a lot of them have just been studies of just for a very short duration of time. So they only look at, so basically they'll randomize half the people to a placebo tablet and half to active drug, but they'll only follow them for like 1 or 2 months, basically. And but then you don't really know whether the drug remains effective over a long period of time. Now, some of the blockbuster drugs like Botox, for example, they have looked at Botox and up to a year, for example, and there might even be some studies that looked at longer than that. But their pivotal trials looked at it for about a year, and found that the efficacy held over that entire time period. But most of the studies of preventives just don't have good long-term data. The only problem with trying to request a proposal to look at long-term data is that you need studies that really have a lot of money behind them. And right now, the kind of money we'd be talking about for the National Headache Foundation probably wouldn't have the number of dollars. You're probably looking at millions and millions of dollars to follow patients over 6, 9, 12 months or even 2 years. So I don't know that would be a practical study for the National Headache Foundation, but if you're asking me, do I think these are important studies? Absolutely. I think looking at how drugs behave over the long run, whether people develop resistance to them, how effective they are they down the road, do they lead to side effects or long-term complications, are very important questions to patients and doctors alike.
All right. Well, that was fascinating, and I think I can speak for everyone. I say thank you very much for joining us and sharing all the information that you had on different research. And it was pretty awesome to get to hear you, since you have some research on some of the specific questions people are asking. So thank you again for joining us.
Yeah, I'd like to say just one thing before we close. I'd like to thank everyone for participating, and I think we'll probably do some more of these in the future where we get your opinions, because I think it's very important for the National Headache Foundation to hear this so we can decide which